Right, let's have a discussion on anxiety disorders now. Now, anxiety is a common emotion. All of us have experienced anxiety once in a while. When we talk about anxiety, we talk about two things. First of all, we talk about certain physiological symptoms. What are the physiological symptoms of anxiety? There may be sweating, there may be tremors, there may be palpitation, there may be heaviness in chest, there may be hyperventilation, there may be nausea, there may be diarrhea, the skin may become cold and clammy, there may be hyperreflexia, there may be increased frequency of urination, there may be diarrhea. All these things are seen during anxiety. And then we also have a psychological component. How does a person feel when he or she is anxious? The term that we usually use is a feeling of nervousness. The person feels nervous. This is what anxiety is on a broad level. Anxiety disorders are disorders which are predominantly characterized by the presence of anxiety symptoms. Depending upon in which particular situation this anxiety is seen, we have divided anxiety disorders into various types. So let us start with GAD, Generalized Anxiety Disorder. Now look at the name, generalized. What does it tell you? That the anxiety is not limited to a particular situation. Say a person has specific phobia. Say a person has acrophobia, fear of heights. This person is anxious only when he is either at heights or is asked to go to height. Otherwise, he is not having anxiety. Whereas in generalized anxiety disorder, the anxiety is not limited to a particular scenario. It is generalized. Sometimes we use the term free-floating anxiety. The person is always anxious. The person is always anxious. When we talk about the phenomenology of GAD, we say there are two main symptoms. The first is the worries which are excessive and uncontrollable, and then we talk about the physiological symptoms of anxiety. So the first one is excessive and uncontrollable worry and anxiety. What exactly is worry? Worry is preoccupation with a future negative event. Something wrong is likely to happen. In worry, the thoughts are all about something wrong is about to happen, and these thoughts are about various domains of life. For example, the person may have a negative thought regarding, say, work or education. Say the person is in a job. The person gets a thought that today my boss did not look happy with me, and what if he scolds me tomorrow in front of everyone? What if he fires me? What if he fires me tomorrow only? What if I lose my job? And what if I lose the source of the income? What if I am not able to get any other job? What will happen to my kids? How will I support them financially? Right? Negative thoughts about future or education. The exams are coming. What if I do not perform well? What if I fail in a particular subject? What if I fail in all the subjects? What if I am thrown out of the college? What will happen to my career? How will I make any kind of money? The worries may be about the health of self. What if I become ill tomorrow? What if I develop some serious kind of illness? Who will take care of the family? Who will take care of my kids? Who will take care of my spouse? Or about the children? The kids are going out to play. They are in the park. What if somebody kidnaps them? What if they injure themselves badly? What if they get run over by a vehicle? What if they get into company of bad people? What if they are abused? It could be about finances. What if the economy becomes bad tomorrow? What if I lose my job? What if the bank takes away the house from me? What if the vehicle is taken away from me? About parents. The parents are getting old. What if they develop some severe illness? Who will take care of them? How will I manage the parents as well as my own family? How will I manage the work as well as the medical problems of the parents? What if the spouse loses a job, right? So all kind of negative events about different domains of life, right? These are, if you look at the anxious thought or the thoughts that are part of the worries, they're about the real life situations. They're about the real life situations. What is the difference between worries that are a part of GAD and the so-called normal worries that everybody experiences once in a while? The difference is primarily in the severity, right? Patients who have GAD, they are more likely to see threat in the day-to-day situation. Every small situation, every mundane situation may trigger these worries. So the extent, the things that make them anxious, the things that make them worry is much more than the worry that a normal individual experiences once in a while. Not only that, not only they see more threat, they also believe that, they also exaggerate the severity of the threat. They also exaggerate the severity of the threat. For example, if a superior in the office looked unhappy with their work, they would not only think that he did not like my work, they may think that he is now about to fire me. So not only they see more threat, but the threat is more exaggerated, and they also underestimate their own coping skills. They underestimate their own coping skills. For example, the boss looked angry, the boss is likely to fire me, and if he fires me, I would never get any other job. So own coping skills are significantly underestimated. So this is what happens in worries, excessive worries and uncontrollable. If you talk to the patients, often they say that they feel that their mind just does not stop. They say that mind keeps on thinking about something or other, it just does not stop. When they say this, they're basically telling you that the worries are incessant. Along with the worries, we also see hyperarousal symptoms. So DSM talks about 6 hyperarousal symptoms, and DSM says that out of these 6, 3 should be present in adults to make a diagnosis of GAD. What are these symptoms? First is, of course, restlessness. The person says that I always feel on the edge. I'm never relaxed. I'm always restless. I'm always doing something or other. I just don't seem to calm down. Muscle tension. The muscles appear tense. They may say that the jaw appears to be very tight, very tense. They may say the shoulder appears very tight. The neck feels very tight. Body kind of feels very tight. And often these patients also have physical pain symptoms. Insomnia. There may be difficulty in falling asleep, sleep onset insomnia, or there may be difficulty in maintenance of sleep, or the person may get up in the morning and feel not refreshed, unrefreshing sleep. Irritability. If you are feeling restless, if you are not feeling relaxed, the muscle is tense, of course you tend to be irritable. You are short of temper, you get angry easily, you get into frequent conflicts with people because you are in that state of arousal. Everything is threatening, you are more likely to fight. Poor concentration. Not difficult to imagine that a person who is restless, who is anxious, who is aroused finds it difficult to concentrate at anything. And also, if you're always restless, if you're always tensed, you get fatigued easily, you're tired easily. So these are the symptoms which are described by the DSM. But apart from these 6 symptoms, there are more symptoms that are often seen in patients with GAD. What are those? Pain symptoms. This is important. These patients often complain of somatic pains, headache, shoulder pain, neck pain, body pain, legs pain, right? And that also has a clinical significance. When you choose a pharmacotherapy, often you have to take into account the pain symptoms. I'll discuss about it when we talk about the pharmacotherapy. Autonomic symptoms. So the autonomic symptoms that we just talked about, the symptoms which are seen in people who are experiencing anxiety, palpitations, sweating, tremors, all of those may also be seen in the patients with GAD. Now this is interesting. Patients with GAD often have fear of unknown or unfamiliar. When they are exposed to a situation that they don't know about, a new situation, they don't feel comfortable. For example, if a patient with GAD is asked, say it's a medical student, and medical student say in one of the states, and the student performs very well and gets selected and has to go to AIIMS Delhi. Now the person is very uncomfortable. I mean, how will I survive in AIIMS? All the toppers comes to AIIMS, all the professors are really good. Would I be able to survive there? What if others laugh at me? What if I am not at their level? What if I am not able to speak well? What if I am not able to give good presentation? Right? So situations which are unknown or unfamiliar, they try to avoid it. And sometimes they take actions on the basis of these worries. For example, this medical student, despite getting selected in AIIMS, might opt to stay in his own medical college. Might just, let go of the opportunity to go to AIIMS Delhi because it's an unfamiliar situation. High intolerance towards uncertainty. These patients feel very uncomfortable if things are not clear, if things are not certain. Again, let's take an example of a medical student. This is something that happened recently. The NEET PG exam got postponed, and there were multiple students who just could not study because they did not know what is the next date. Unless they know when are they expected to give to take that exam, they are not able to study. They're very uncomfortable, very uncertain. This is what is the meaning of high intolerance towards uncertainty. It is also seen that patients with GAD are often not even aware of their emotions, and if they are aware, they are not able to accept it. So underlying anxiety, underlying emotions of anxiety which are there, which are painful, they are regulated by dysfunctional ways. One of the ways is reassurance seeking. The example that I took of the student who became uncomfortable when the exam got postponed, what did they do? They messaged every single faculty that they know of, asking when is the exam likely to happen. They would go on social media and would try to find out some clues, some evidence, some information about when the exam is about to happen. Or they may go and talk to people and they may ask them that, will the exam happen in next 1 week? I hope it is not going to be announced in the next 2 weeks. Reassurance, asking somebody should tell me what is going to happen. Somebody should reassure me that you study, it would be at least 1 month away from today's date. This is reassurance seeking. Another example would be, say there's a homemaker who is worried about the health of the children, that the kids are going to the school, what if somebody kidnaps them? Now she would go to another mother and would ask her, is it okay to send kids to the school? Is something likely to happen? Is school safe? And when the other person says, yeah, everything is okay, everything is fine, don't worry, then she feels a bit better. So reassurance seeking. Another way is cognitive avoidance. Not thinking about it. The person says that when I think about these things, I feel very troubled. It's a very unpleasant experience, so I would not think about it. So avoidance is never good. So this is what we mean by dysfunctional ways of emotional regulation. So what is avoidance model of worry in GAD? This is the avoidance model that the patients have underlying anxiety and they don't want to deal with that anxiety. So worry basically helps them in avoiding the underlying anxiety. When the person keeps on thinking about the possible scenarios, possible negative scenarios, they are able to avoid the underlying anxiety emotion. Avoid the underlying anxiety. There's another very interesting hypothesis regarding worry. So the hypothesis is, why people worry? Because they feel that, or because the pain or the discomfort of worrying today is much better than the pain if something unexpected happens. So it's like, if I worry today about my health, that what if something goes wrong with me, what if I develop some serious illness, basically I am safeguarding myself from the pain or the shock that may come my way if I actually develop some serious illness 6 months from today. So rather than facing that bigger pain, let me face this smaller pain. And this is also hypothesized that worrying is an attempt to take things which are out of your control in your control. It's like you cannot do anything about something that is about to happen. So by thinking about it repeatedly on a loop, you feel as if you're preparing yourself for that event. So all of this is avoidance model of worry. Primarily, when we talk about avoidance model, we say that to avoid the underlying anxiety emotion, the person tends to worry. All right. So what is the duration criteria for GAD? 6 months. If the person has symptoms of worry and the associated symptoms for most of the days for a period of at least 6 months, then you can make the diagnosis of GAD. And like all psychiatric disorder, there should be either distress or a socio-occupational impairment. Epidemiology of GAD. GAD is a very common psychiatric illness. The American studies have shown that the lifetime prevalence is around 3 to 6%. That's a huge number. And GAD is more commonly seen in females. 1.5 to 2 times as to 1 is the ratio. According to the World Mental Health Survey, now this is interesting, most of the anxiety disorders tend to peak by the age of 25 years. The onset is usually before 25 years, not in the case of GAD. As people keep growing older, more and more of them keep on developing GAD. In fact, 25% of the GAD cases, only 25% emerge till the age of 25. Another 25% in the next 14 years. Another 25% in the next 14 years. So from 25 to 39, 39 to 53, more and more patients are developing GAD. So it's still possible for someone to develop GAD onset after the age of 53. In the 50s, the onset is happening, and that too not a small number, a number as high as 25%. So this is a difference in the onset of GAD in comparison to other anxiety disorders. Other anxiety disorders tend to peak early. Differential diagnosis. So of course, normal worry, as we discussed, that a patient with GAD is more likely to see threat in multiple situations, exaggerate the threat, and underestimate the coping skills. Other anxiety disorders, so for example, anxiety disorders like phobia. Now in phobia also there is anxiety or worry, but it is limited to that particular thing. If a person has acrophobia, the anxiety is limited to heights. If a person has social anxiety disorder, the anxiety is only about the social situation of facing embarrassment in social situations. If a patient has panic disorder, the anxiety or worry is only about the next panic attack, the anticipatory anxiety. If a person has agoraphobia, the person is only anxious when he is in a situation from where escape is difficult. But a patient with GAD is worried about multiple aspects. So that is how you differentiate. A patient comes to you and patient says, "Doctor, I am worried about health, that I might develop some kind of health condition." Do you diagnose this person with illness anxiety disorder or GAD? The answer is simple. You ask for more history. Is the anxiety limited only to health conditions? Then you make a diagnosis of illness anxiety. But if health anxiety is one of the components and there is anxiety about multiple other things, then your diagnosis goes towards GAD. So illness anxiety disorder, somatic symptom disorder, same thing. If anxiety is about different domains, you go towards GAD. Major depression, we know that there's a specifier, major depression with anxious distress. Patients with depression may also present with anxiety symptoms. So in that case, do you diagnose them with GAD with MDD or just major depression with anxious distress? Depends primarily on multiple things. One of the things would be the temporal relationship. If the onset of symptoms was with depressive symptom and then the person developed anxiety symptom, or they were developed simultaneously and the depression predominates the clinical picture, then probably you will go with major depression with anxious distress. But if you find history that the patient has been anxious for say 3 years, for 6 months the depressive symptoms have also developed and they are clinical, in that case you make a diagnosis of GAD with MDD. Similarly, other disorders like say separation anxiety disorder. If the anxiety is only At the time of separation with the important figures in life, you make the diagnosis of SAD. If the anxiety again is involving all the domains of life, you go with GAD. This is pretty straightforward. Comorbidity is a rule, right? 80 to 90% of patients do have another psychiatric illness. Almost 60% of them have depression, depressive disorder. Apart from depression, other anxiety disorders like phobias, like panic disorder, like agoraphobia, like social anxiety disorders, they are also often seen in patients who have GAD. Substance use disorder, another comorbidity. Now, interesting is substance use disorder because many times you will see a person who has GAD who consumes alcohol or consumes cannabis and realizes that alcohol or cannabis calms him down, and then that acts as a reinforcement, and before the person realizes, there's development of substance use disorder. Not only psychiatric disorders, medical disorders are also often comorbid. First of all, these patients may often have somatic complaints. They often get the diagnosis like fibromyalgia. The orthopedician may diagnose them with fibromyalgia or IBS, or they may have comorbid diabetes or hypertension or obesity. So somatic complaints and medical disorders are often comorbid with GAD. Now the course of GAD is waxing and waning. The symptoms tend to increase, then there may be a period in which the person has no symptoms, then there may be increase in symptoms, right? So they tend to be waxing and waning, and there are recurrent episodes. In some people, the episodes are of lesser duration, in some the episodes are of longer duration, but recurrence is quite common, right? There will be multiple episodes. If you look at the first episode and if you look at the last episode, and if you see that out of the entire period, for how much time the person was symptomatic, that comes out to be around 50 to 60%, which means that these patients are for more than half of the time symptomatic. So evaluation, you have got multiple tools. You can use certain general tools for anxiety, like your Beck's anxiety inventory. There are certain screening tools for GAD like GAD7 screening tools. And then if you want to use more structured tools, you can go for standardized interviews or structured interviews. So you have CD, which is not only for GAD but for other psychiatric disorders also. Similarly, you can use KID, which is based on DSM-5. You have MINI, and you have KSATS, which is Schedule for Affective Disorders.